A 68-year-old female presents with chronic knee pain and joint swelling. I am showing you anteroposterior and lateral radiographs of the knee. Please describe the findings.
The anteroposterior radiograph demonstrates joint space narrowing of the medial compartment, tibial spine spurring, and linear calcifications within the medial meniscus and hyaline cartilage. The lateral radiograph reveals severe patellofemoral joint space narrowing and curvilinear suprapatellar calcifications.
What is your primary diagnostic concern?
The findings of chondrocalcinosis involving the meniscus and hyaline cartilage, combined with patellofemoral predominant osteoarthritis, are diagnostic of calcium pyrophosphate deposition disease, or CPPD.
What is the clinical term for the radiographic finding of cartilage calcification seen in this case?
This is chondrocalcinosis, which represents calcification of fibrocartilage, such as the meniscus and hyaline articular cartilage.
How does the pattern of joint compartment involvement in the knee in CPPD differ from primary osteoarthritis?
CPPD characteristically involves the patellofemoral compartment, often in isolation or with severe joint narrowing out of proportion to the femorotibial compartments. Primary osteoarthritis typically affects the medial femorotibial compartment first.
Which other joints in the body are classically affected by CPPD, and what are their specific radiographic findings?
Classically, it involves the radiocarpal joint of the wrist, demonstrating subchondral cysts and narrowing, and the second and third metacarpophalangeal joints, showing hook-like osteophytes.
What metabolic disorders are associated with chondrocalcinosis and should be screened for?
Associated disorders include hyperparathyroidism, hemochromatosis, hypomagnesemia, and hypothyroidism. Screening with serum levels of calcium, iron, and magnesium is indicated.
What is the differential diagnosis for cartilage calcification?
The differentials include gout, amyloidosis, and achronosis. Gout typically presents with soft tissue tophi and punched-out erosions, which are absent in this case.
Finally, what are your clinical management recommendations?
I recommend joint aspiration for crystal analysis to identify weakly positive birefringent rhomboid crystals under polarized light. I would also suggest referring the patient to a rheumatologist or primary care physician for symptom management and metabolic screening.